Achieving clear, radiant, and smooth skin doesn't have to be complicated. It's all about learning how to care for your unique skin type. Welcome to the Skin Coach in Georgia, the podcast dedicated to teaching you about healthy skin, what it takes to clear your acne, and age gracefully. I'm Mayade Samimi, a former acne sufferer turned medical esthetician and founder of Urban Skincare Clinic. I've helped thousands of women just like you love their skin again and get compliments. It's been my calling to be an esthetician friend to other women, someone I desperately needed by my side when struggling with acne but didn't have. So, let's improve your skin's health starting now. Welcome back to another episode of the Skin Coach in Georgia podcast, sponsored by Urban Skincare Clinic. I have a special guest for you today in this episode, Dr. Marc Yune, who is a triple board certified facial plastic, cosmetic, and reconstructive surgeon by the American Board of Facial Plastic and Reconstructive Surgery and the American Board of Head and Neck Surgery, a diplomat of the American Board of Cosmetic Surgery, and a fellow of the American Society of Cosmetic Breast Surgery. We had a great conversation around facelifts, the best time for elective procedures, the difference between silicone versus saline implants, and more. And without further ado, I'm going to play that interview. All right, Dr. Yune, welcome back to the Skin Coach in Georgia podcast. So glad to have you here today.
It's quite an honor. I enjoy talking to you. So thanks for inviting me back.
Wonderful. We had a great conversation last time around injectables. We touched on facelifts, blepharoplasty, and I'll be sure to link to that episode in the show notes so people can go back and listen to. But I thought we'll dive right into the questions this time.
Great.
How does that sound? Great.
Let's do it.
Is there a best time to consider elective procedures?
You know, I think what makes people happy and what I like to refer to as happy medicine is addressing what bothers them. I think that as responsible providers, it's really our job to educate and not sell. So what I'm getting at is when it bothers you enough that you want to come seek somebody like me to address an issue. And then if you have realistic goals and the surgeon or the provider can deliver that safely and effectively, then you've got a happy result. So really, that's what we're shooting for, trying to satisfy patients and give them happy medicine. So you really have to focus on what the patient's concerned about.
Regardless of their age.
Yeah, it's not a chronological issue. It's an anatomic issue and it's an emotional issue. That's what you have to prioritize. So it's elective, like you just said. Nobody has to be here to see me. They're here because they want to be. And I think one thing that tends to happen, especially with the competitive environment, is I hear a lot of my colleagues suggesting surgeries that maybe the patient didn't even think about. But I feel like that's probably a turnoff for most people. I don't like seeing my profession go down that direction of sales. I think we need to still keep it very professional, be objective providers. So it's just kind of my slant on how I handle
patient-led. I am right there with you. When someone walks into my clinic and they want me to tell them what needs to be corrected, I put it back on their court. I put the ball back in their court and I'm like, it's up to you. Tell me if the redness is not bothering you, it doesn't bother me. If the sunspots don't bother you, it doesn't bother me. Let's correct what you would like to see improvements. So wonderful. There is a newer form of non-surgical injectable on the market, at least newer to the US as far as I am aware, called threads or thread lifts. Can you tell us a little bit about this new procedure? What is it? Is it FDA approved? Any pros or cons?
So that's a good question. I get asked about it a bit. Threads actually are not new at all. The concept of thread lifting has been around even when I started my career almost 30 years ago. In fact, I played with certain types of technologies, including Gore-Tex threads, Prolene threads. The idea being trying to lift the face without doing incisional surgery. It's not a filler. It can convert to a filler, which is what happens with what's called the polylactic acid threads. That's the generic name for Sculptra, which is an injectable, and it stimulates collagen growth. But we don't offer it because I quit doing it many years ago. It's inherently flawed because of a material science issue. So what I'm getting at is threads are not stretchy. They're stiff, like fishing line, for instance. But your face is mobile. So after enough movement and animation and washing your face, and your threads don't hold. So the average patient will tell me that they like the initial result if they didn't get the dimpling that can happen with threads, because it has to hook into your skin underneath. And they pull through. That's what I mean about a flaw in material science, because the thread doesn't stretch with the face. The perfect thread would be one that doesn't create a dimple and never breaks, like a rubber band. And that doesn't exist in our world today. So I still think it's not a high dollar value treatment for the patients. Everybody that comes to me with a thread history says it's just about gone in 6 months. Sometimes it lasts a year or so, but they're disappointed with what they got out of it.
So does it over time dissolve?
So one of them does. That's the polylactic acid thread. So here's the interesting history of how that's evolved, at least in my opinion. And I'm just one guy, but I've been around a while. The polylactic acid threads, which create a scar tissue replacement, collagen replacement, a little tube of collagen. And since it wasn't really holding as well as they wanted, then they started playing around with using it to put threads under the nasolabial folds, even in the lip border, to give you volume. So that was the concept, is to maybe change gears altogether and not hook the skin, but actually build collagen.
Absolutely. Okay.
Yeah.
Wonderful. Wonderful. Let's move into facelifts yet again. We touched on it last time, but if we can go a little bit more deeper this time, that would be great. Who is an ideal candidate for a facelift? When is the best time to consider one? And what is the difference between a mini facelift versus a full facelift?
All right. Well, kind of goes back to my original concept of who is a good candidate and when is the best time. I think I covered that concept with our opening question, which really comes down to, does the patient have the right desire? Are they here because they want to be? Are their goals realistic? Are they healthy enough to do so? These are very important criteria because we have to emphasize safety over anything. Then, are you capable of delivering a safe and excellent result? I think when we start getting outside of our lane, this is where we see some complications. So you really want to see somebody that kind of specializes in what you're looking for. Plastic surgery is such a diverse field now. We have surgeons that just do facial cosmetic surgery. We have ones that just do facial reconstruction. Some people just do children. So some people just do wounds and burn clinic. So it's important to find out what your surgeon can provide. And then the mini versus the full. So this is a great question too. I get a lot because what happened, interestingly enough, so the deep plane facelift, the long skin flap deep plane facelift was always the gold standard. That was kind of what was taught even during my fellowship training, which was in 1996. That is what makes the lift look natural, makes it last longer, because you're elevating the deep plane, which is the muscles and the fascia, the SMAS. And when you put the tension on the deeper layers and not too much tension on the skin around the ear, then the scar remains thin. It doesn't distort the ear because skin can't hold tension up. It pulls the ear down. So what happened over time is, we try to listen to patients. We try to listen to the industry, and patients wanted less downtime. They wanted a less invasive surgery. They didn't like the concept of having to get a facelift. So marketing and trying to answer that call, many practices de-evolved the facelift. They made it into mini facelifts, which are short skin flaps, tension on the skin, not a lot of hold, almost like the thread lift, where it kind of disappeared in 6 months to a year, but it pulled the ear down with it. there was a group called the Lifestyle Lift, which ran into some legal troubles because the TV commercials did not quite equate to their outcome. And I don't know the details of that, so I don't want to get into legalese, but what I'm getting at is the mini facelift really is using a similar incisional pattern. So you're still giving people the same incision, but it's a lesser result. So that's great. You can do it at your lunchtime and have minimal swelling. But at the end of the day, a patient is not satisfied with the result, especially if it's a surgical result that only lasts a year or so, especially if it distorts the ear. So the gold standard is still the deep plane. And yours truly was one of the early creators and adopters of the Botox assisted facelift. So that is the only thing that I think modernized the deep plane. That's Botoxing the muscles that pull the face down. These are off FDA label, the DAO and the platysma. And then 2 weeks prior to doing the facelift, when I do that and it has time to set up, while the patient is healing and it's not sturdy till 6 weeks, it helps reduce the patient from pulling the lift down a little. I feel like the Botox assisted facelift maybe stays up 10 to 30% better. And then just understanding how to use that post-operatively to maintain the lift. So that's a long-winded answer, but it's an interesting question because as I've watched throughout my career, the facelift go from really awesome to de-evolved to back to being good again. So that's what social media helped. A lot of my colleagues who get on social media have educated patients that this is the gold standard. You have to be educated, and unfortunately, a lot of people will market to you things that sound nice, but when it sounds too good to be true, maybe question it. It's good to get a few opinions, you know.
Absolutely. I'm right there with you.
Yeah.
Wonderful. Last time we touched on botched plastic surgery jobs. I'm sure you see a lot of it in your practice. What is your unique approach or technique to quote unquote kind of fix these plastic surgeries gone wrong?
You know, that was kind of my passion when I was going through my fellowship because I had the opportunity to see and scrub in and perform on 1,500 surgeries. And what I saw repeatedly, and in a facial fellowship, you have to author a paper. You have to do a scientifically relevant study. So it's not just surgery too. You have to contribute to the community. I saw a lot of over-resected noses. Now it's being called botched nose jobs, which kind of simplifies it, but people understand that. The over-resected nose is the one that's too pinched, too short, too rotated. So I created the DART procedure during my fellowship, and that was actually taking structural grafting, your own cartilage from your septum. That's the middle structure in your nose, your ear, or your rib cartilage, and creating a tripod. So consider 2 cartilage grafts alongside your septum and 1 at the base. And when you connect the 3, you've got a tripod where you can control the arc of derotation, pushing the tip down. You can control the projection of the tip, taking a short nose and making it more, projected. And then suturing the tip cartilages, which were oftentimes over-resected. Sometimes you just see a remnant of cartilage. That was not uncommon in the old days. That's allowed me to reestablish derotation, projection in a controlled manner, which, in my opinion, was the first time we ever described that while simultaneously opening the airway. So the DART happened, in 1997. I published it then, and it's become quite popular worldwide as the go-to for the over-resected nose. Prior to that, cartilage grafts were stacked on top of an already foreshortened nose that was weakened because it doesn't have enough cartilage. That might look okay, but it actually obstructs the airway further. So you don't want to give somebody a cute nose that they can't breathe through.
No, that would not be good.
That was the DART, and that was my first contribution. I'm really pleased to have brought that, and it kind of differentiated our practice because we could handle what a lot of people consider the trickiest cases, revision rhinoplasty. The other one that we just authored, 2016, was the ICE procedure. That's taking the malpositioned breast implant that's either too low or too to the side, maybe too big a cleavage in between. It looks like a bad position breast implant. It's not a droopy breast, it's a droopy implant. So historically, that was removed. The patient's natural tissue was sutured to the ribs and the sternum to lift the implant. That would oftentimes, surgeons hated that procedure because it's difficult to make it look good it's kind of like the thread lip. It created dimples.
Mm.
It's really hard to place those sutures. It's a cumbersome surgery, and I didn't never performed it because I didn't think it ended up in a better result. It actually ended up in a worse result. But then it dawned upon me that I could actually use the patient's own natural physiology of healing to itself, scar tissue, to do the work of the sutures. So instead, what I'm doing is I'm doing a fractionated cautery of the inside of the capsule along the bottom of the implant, and then I'm just putting them in a bra. A sports bra that defines the new curvature of the bottom of the breast, which makes it look very natural. I mean, that's what sports bras are built for, right?
Mm-hmm.
And I just put a band on top. And that is what I call the trap wrap.
Mm.
But then this way you can take an implant and move it toward upward or medial with great control. And I felt like we had a nice contribution here because it took one of the most difficult surgeries and made it one of the easiest with predictability. But it took me from 2011 to 2016 to find 3 candidates that would let me try an experimental surgery on them. And finally, after 3, the journal accepted the publication. This is American Journal of Cosmetic Surgery. The DART was American Journal of Facial Plastic Surgery. It was just the Facial Plastic Surgery Journal. They took the paper and accepted it, so we were able to present it at the National Cosmetic Surgery meeting, and it was a big hit.
Very nice. That's
Yeah.
awesome. Well, speaking of breast augmentation, what is the difference between silicone and saline-filled breast implants?
Well, I'm glad you asked me that question too. For me, it's all about safety first, long-term successful outcomes, patient satisfaction, but safety first. And I'm fairly unique in that I'm one of the few breast augmentation surgeons that don't offer silicone. I realized early on in my career that a lot of the women who were having trouble had a history of a silicone implant and capsule contracture. So what happens is the breast actually forms excessive scar tissue. It's calcified, it's hard, and it actually causes the implant to shrivel up or kind of get into a tight pocket. And so there's levels of capsule contracture. So level 3 is hard. Level 4 is hard and painful. That's like the worst. If you need to go in there and remove that capsule tissue, it's like doing a partial mastectomy. I've never seen it in a virgin saline implant in nearly 30 years. Every time I see it, and the industry will tell you that it seems to be related to both implants. All I've done is saline. I've been told that if you say you haven't had a capsule contracture, you're not telling the truth. I've never had a capsule contracture. What I have had is a capsule contracture secondary to a previous silicone implant that had capsule that leaked. I had to remove it, replace it with saline. The reason why I think that capsule reforms is because you can't get rid of all the leaky silicone because it's in your tissues. It gets into your breast tissue, it gets into your lymph nodes. So it's sitting there still brewing that inflammatory process.
Right.
So in my humble opinion, I don't think silicone should be offered still. I want to say the initial data that allowed it to get FDA approved many years ago, maybe 2007, I can't remember, is that there was about 8 to 15% chance grade 3, grade 4 capsule contracture. So for me, that's just too high odds for complications. So we just try and keep it really simple. And, saline, if it leaks, it doesn't hurt you. It just absorbs like IV fluids, right? It just goes flat, so you know it. The new silicone implant is cohesive gel. So you got to realize silicone was taken off the market for breast implants in 1992. There was a Dow Corning class action lawsuit where almost all those women got capsule contracture because the implants almost all leaked. And it was an oily silicone, so it was very inflammatory. Somehow they created a cohesive gel, which has the cute nickname, the gummy bear implant, makes it sound cute and simple and safe. And so when you cut it, if you put the implant on top of a table and you cut it, it doesn't leach out. It stays pretty stuck together, which is good that it doesn't get out so much. It makes it a little safer. I will admit that, but it still leaches out a little bit, causing capsule contracture. And again, once the cat's out of the bag, you can't get it all out. And it's a silent leak. So you can't screen for it with mammogram. You can't screen for it with physical exam. You may not even know you had a silent leak because it's sitting there fairly cohesive until you start getting the capsule contracture. So to monitor that, a yearly MRI, or maybe every other year, which is very expensive, It's just a headache. So I don't even offer it, but I'm probably in the 1% category. Yeah, I'm actually kind of known for being the saline guy because I refuse to put silicone in. So I wouldn't put it in my mother or sister. So I'm not going to put it in you. Sorry for the long answer, but I'm
Love
kind of
that.
passionate about, silicone versus saline. I'm going to probably get some hate mail from this, I'm sure.
I love that. I mean, safety first, like you said, safety first.
Yeah.
Absolutely. Now, where do you see as future trends in plastic surgery, aesthetics? We're all ears.
Well, I think patients are always demanding less downtime, less invasive procedures. So the trend is largely going to non-surgical. For instance, in my office, we offer over a dozen devices that can get rid of discolorations, get rid of unwanted hair, tighten your skin with heat using ultrasound and radio frequency, kind of like the non-surgical facelifts. We've got cool sculpting, which reduces your fat by just freezing it without doing liposuction. Cool tone, which uses magnetic muscle stimulation to give you further muscle tone, abdomen, buttocks, and thighs. Really cool device. It doesn't replace the fact that you should exercise, but it enhances that. Not well known, but it's a great device. We've got Thermi, which is radio frequency to help rejuvenate the skin. It even helps with female rejuvenation. And one of the favorites for my patients is it helps reduce stress urinary incontinence for the women. So it's called ThermiBall. We have a very new technology that's so new on the block that not a lot of people know about it, called Cleovana. This is sound wave technology, which an orthopedic surgeon ingeniously invented on his own family member, which with sound wave technology, it regenerates nerves, enhances blood flow. They used it to heal non-union bone issues or tendinopathies. So it's been around for a long time. But he applied it to the clitoral area, and it's enhancing orgasmic potential over 80% after 4 treatments. Not painful, 10-minute treatment. Patient can actually do it themselves. And I think it's going to be a real game changer for women who aren't even dysfunctional. It helps the person who's functional be even better. It's a quality of life issue. It's embarrassing to talk about for some people, but with my wellness clinic, I have got a lady who's helping perimenopausal, menopausal women get through their aging process with bioidentical hormones. Mm-hmm. Another really awesome thing to add to cosmetic practices is wellness, preventative medicine. So she deals with sexual questions a lot. Wellness is really a great addition to cosmetic surgery because it really is kind of all the holistic approach. Like I always tell my patients, I'm going to make you look good, better, younger, whatever, but we really want you to feel good on the inside too. So our wellness program involves using supplementation. There's so many supplements that are beneficial that people are missing out if they're not educated about this. Everybody listening to this podcast needs to read about wellness and supplementation and bioidentical hormone replacement therapy. BHRT has probably been one of the most useful things to help people age gracefully. See, when I went to med school, they didn't teach us about preventative medicine. We were taught how to take a sick patient and make them better. Mm-hmm. We call it taking a pill for your ill. Mm-hmm. Whereas the preventative approach is really, let's prevent disease with good nutrition, supplementation. And then when the hormones start to deplete, we help people go through menopause or manopause by boosting them with bioidenticals. And that's the key, not synthetics. The Women's Health Initiative, which featured over 33,000 women, was testing Prempro, which was female hormones derived from equine urine. I don't know who came up with the idea of getting, pee from a horse and put it into a woman to make them age better. It was causing more cancers. It was actually stopped because it was actually more dangerous. And then all of a sudden, the entire medical community said, hormones are terrible. Well, synthetic hormones are bad. And we know about anabolic steroids. We look at the bodybuilders and how it looks great in the beginning. They get so built and then it just ruins them. All right. So you got to stay in the bioidentical lane. And these aren't derived from animals. They're derived largely from plant. And then they're synthesized to be very similar to your own hormones so they don't damage you. They actually reduce the risk for stroke, heart attack, cancer, Alzheimer's, Parkinson's, you name it. The specialty of wellness is growing just as quickly as cosmetic medicine. It's really an important part to adopt because I don't think we should just superficially scratch at the surface and make people look good. I think we need to give them good health. So that's one of my favorite additions. And then who knows what the future will bring? There's a cool product coming out that is platelet-derived growth factor, and it's been used in also orthopedic and oral maxillofacial procedures. It's the first FDA-approved growth factor that really seems to be boosting wound healing, rejuvenation of skin, hair growth without having to do anything invasive. It's a recombinant DNA technology taking blood from the blood bank and then creating a very robust growth factor out of it that is very much more efficacious than our own blood, PRP. Everybody knows about PRP, I think, but it's better than your own platelet-rich plasma, up to 30,000 times more effective. So I have my hands on it. I'm going to try it on myself. Jury's still out, but the studies are awesome. So I'm really pleased to be able to offer that soon, hopefully. But our gold standards are still, Botox, fillers, of course, all the cosmetic surgery that I do. And they're still here to stay, but it's really been fun to watch the development of all this non-surgical stuff happening. How's that for a short answer?
Absolutely. It was great. I can listen to you for hours, but we're up for time. Again, thank you so much for coming on. And I will have all the links in the show notes for people to find you, connect with you, and come in for a consultation.
You're so awesome, Maya Day. Thanks for having me. I appreciate it.
Thanks, Dr. Yune. Bye for now.
Okay, take care.
And that's a wrap. Share this episode with a friend and check out Dr. Yune at Aesthetic Specialty Center. Until next time, take good care of yourselves. Bye for now.